and welcome. Today I've got a challenging case that is commonly found in most glaucoma specialist practices and possibly some general ophthalmology if you end up with complex cataracts. So this is a patient who's had 2 shunt devices placed and has not yet had their cataract out. There's your temporal orientation. I'd like to highlight a couple interesting maneuvers that are done to make this case work and a few of the pitfalls. So we're doing our typical viscoelastic and keratome entry. And then notice down at about 6-7 o'clock, the pupil is fused to the capsule. So I like to go around with the Kugelin hook. I like to do 2 runs because I tend not to get everything the first time around. And there we go. Now I'm going to go in with a Rex's forceps and grab that membrane. That's a little fibrotic membrane. And if you pull that off, tease it off real careful, a lot of times that is what was holding back the dilation. Not that glaucoma eyes tend to dilate well anyway, but there we go. Once the membrane has been released, you can see the pre and post size there with that little ghost view. So now I've got a reasonable sized pupil. However, I got a tube in the way, and we can't ignore this. This tube was left long by the surgeon, and this is my technique for trimming it. Just grab it, go in with your little MSTs. I thought I could pull it out through the pear, but that wasn't going to happen. So just teased it out through the main wound, and there we go. Now we're ready for our trypan. Trypan is done under viscoelastic, no air. Don't put air in glaucoma eyes. When the air bubble collapses, you'll end up shocking the whole anterior chamber, and these eyes are at much higher risk of going into malignant glaucoma. There is no air really needed anyway. So just do a little trypan, then a little more viscoelastic, and I'm going to speed up the Rexes here because there's nothing super interesting. I've shown this technique before. It's actually under the iris. The pupil is about a 5 millimeter pupil, so I'm going just under the edge, and folding the capsule under the iris like this actually is extremely controllable. Even though I don't actually get to see the location of the tear, it just kind of goes right around in a circle. Here's my Chang cannula doing the hydrodissection. Once again, it's a little bit of a blind maneuver, but if I drag the cannula along the cortex, I know I'm under the capsule, and then I can spin the thing around, and we're good to go. Here is the MyLoop. This is an extremely dense cataract. This patient is well over 90, and this thing is a brick. So I just go straight to the MyLoop in these cases. You could probably battle it out with the phaco, but why bother? The MyLoop applies the energy in a very cornea-friendly way and makes short work of a nucleus, even one as dense as this. So again, I'm going to show a little bit of phaco once you've got the MyLoop chopped into quadrants. And here I'm purposely not breaking it up into additional pieces. I'm trying to actually keep the quadrants whole and just kind of nibble them away, because I don't want shards of and fragments of nucleus flying around to potentially get lodged in one of those tubes. We've got tubes on both sides of me, and I just want to kind of eat these chunks up and get them out. So it's a pretty useful technique when you don't want pieces to fly, especially if, like, let's say you have a capsule that's broken and you've got some viscoelastic down there, and you really don't want a lot of pieces floating around. You can just nibble it away and rotate it. So I'll do a little bit of the large heavy cortex with the phaco, but then I'm going to get out of there as soon as I know I've got the last piece. And we're going to do a handoff maneuver. This is extremely helpful in these cases where I put the viscoelastic in before I undo the pressure and release the handpiece. And again, the whole idea here is to keep the chamber formed. We don't want the chamber to collapse. When the chamber collapses in glaucoma eyes, that's when bad things tend to happen. More than one glaucoma eye has gone into malignant glaucoma right there on the table for me. So We like to avoid that. We like to keep the chamber as formed as possible. Notice what's happening to the iris here. So this is really common with glaucoma eyes. The pupil just doesn't have a lot of tone. And even though I didn't really mess with it during the phaco, just the pressure and the instruments going in and out, it just starts to get really floppy and starts to head out the door. Using a ring won't help here because the tone of the pupil is so poor, the ring will often tear right through and become just one more nuisance in your way. So this is the better maneuver, is to make a new para and sweep the strands out of the other para, wound, whatever's needed. And there you have it. Sometimes that is the best you can do with these glaucoma eyes. And thank you very much for your attention.